My name's Professor Allyson Pollock, and I work at Queen Mary, University of London.
If you wouldn't mind pulling the microphone forward a little bit just so we can hear your voice.
Okay.
Thank you. You have in front of you your statement. Can you confirm it's true to the best of your knowledge and understanding, and that you wish it to stand as your evidence to the Commission?
Well, I haven't read through the draft, but I'm sure if it is as I sent, I'm sure it'll be fine.
Can you please just help by explaining a little bit more about your specific area of expertise?
Well, I trained as a public health doctor, trained in medicine, and then I did public health. And I suppose for the last 20 years, I've been doing quite a lot of work looking at health system changes and reconfigurations, especially those associated with the private finance initiative. So I suppose that's why I've been asked to give evidence today.
I want to ask you a question, and please do feel free to tell me that it's impossible to answer in this way. You talk about the 2012 Health and Social Care Act. Are you able to encapsulate the main thrust of what it does?
Yes, I'll do my best. I think the key part of the Health and Social Care Act, which we've got to be really concerned about, is the abolition of the duty to provide, on the Secretary of State, to provide listed services throughout England. And that's a duty that's been in place since the 1946 legislation, so since 1948. And that was actually abolished through sections 1 and 3 of the health in 2012. So that was sections 1 and 3 of the 2006 Act, NHS Act. And that's a really important duty, that duty to provide. So what it means in lay terms is, in effect, without that duty, there's no anchor to provide a national health service throughout England. And I think that's the prism through which many of these changes that we're seeing now have to be looked at. So there's NHS funding that's in place, but what we're seeing increasingly is a fragmentation of health services. They're dismantling, they're unbundling, and then actually they're privatisation. So in effect, what this means without that duty is that services increasingly, they're untethered from that duty to provide, because that duty to provide was transmitted from the Secretary of State to area-based, geographically based area health authorities. And that's what I think we should keep coming back to, what that abolition of that duty actually then means for local residents in local areas. And I think the second part of the Act that's important is the entrenching of contracting. The contract is the mechanism now through which clinical commissioning groups are actually contracting for services. So prior to 2012, it was quite possible for primary care trusts to still directly provide services, and to do so through the internal market, through a mechanism of block grants or block allocations known as service level agreements. But what we've now got is increasingly commercial contracting. And so we've got a different arrangement for the allocation and management of the risks and costs of care. So formerly those risks and costs were largely held, the duty to provide meant that the Secretary of State ultimately had the duty and would hold the risks, although since the internal market there'd been an attempt to divert those risks to trusts, hospital trusts. But now we've got a very different arrangement for managing risks, which is going to be through a commercial contract. And of course you can't put a duty to provide into a commercial contract. And I think that's really important to understand the way in which the organisational structures and systems are being organised around new arrangements for managing risk.
Thank you.
Does that make sense?
No. What I wanted to ask you about then is this. In essence, because you refer to the duty of becoming a duty to promote now rather than to provide, is the difference between them that one creates an absolute obligation and the other is a more qualified obligation?
Well, there's always been a duty to promote comprehensive service, but sections 1 and 3 made it very clear there was a duty on the Secretary of State to provide listed services, and those listed services in section 3 include hospital accommodation, mental health, community services, services for maternity services. Now CCGs, the duty to promote is still in place, but it's a much weaker duty. It isn't a duty to provide, which was an absolute duty. And CCGs have to make sure that they can meet the reasonable requirements of their members.
Now, turning to denationalisation, which you mentioned, how does that become possible?
Well, it comes back to the fact that you've removed the duty to provide services, listed services throughout England. And that's really very important. So you have NHS funds, but they're no longer tied to an obligation on the Secretary of State to provide those services throughout England and through the geographically defined area-based authorities, because the Secretary of State delegated that duty through area-based structures, health authorities, and then through primary care trusts.
Now, you've touched on...
And there's been a sort of steady attempt to erode or to fray that duty to provide with the introduction of the internal market in 1990. So the internal market tried to bring in competition, contracting through a shadow market, and of course established hospitals and community services as trusts. So there was an attempt, even then from 1990 onwards, to uncouple the planning and needs assessment from the direct service provision. So formally, from 1948 to 1990, area-based health authorities had an obligation not just to meet the needs of their local population, but to directly provide those services. And they did that by directly managing the hospitals and community services in their area. Now, since 1990, the internal market weakened that obligation because it introduced that mechanism of the contract, and it established foundation trusts, but there were checks on their freedoms, quite substantial and significant checks on those freedoms. And of course, area health authorities and primary care trusts still, because of that duty to provide, still had, if you like, a loyalty to ensuring that there were services in their local areas for their residents. And that's actually what's been completely abolished with the 2012 Act. There's no duty to provide. They have a duty to arrange, which is contracting those services, and an overarching framework duty of a duty to promote. And that's the framework duty. And then CCGs only have a duty to arrange, which is a contracting duty using a contract.
So just coming back to this contract issue, are you saying there's a significant difference between how the PCTs worked and how the CCGs now commission work?
Yes, absolutely. And I think it's one of the lines of inquiry for CCGs, how they do work. And I think there are a number of fundamental differences. CCGs, though are not actually area-based except for emergency care. They're membership-based organisations, CCGs, and you become a member of your CCG by virtue of joining a general practice. The second issue is that we've seen the major carve-out of the public health functions. So public health has been carved out and removed from the NHS and moved to local authorities, which means that there's no internal capacity for needs assessment or planning or information. We've also had major changes to information as well. Instead of which there's been CCGs are increasingly, as we've seen in North West London's case, outsourcing the commissioning functions to McKinsey's and PwC. Or we've seen these non-statutory bodies of clinical commissioning service units, CSUs, being established, where the government increasingly would like to float them off, but they are non-statutory. So we've seen major radical changes to the mechanism, the CCG composition, who it represents in terms of accountability, and also the resource allocation mechanisms, which were meant to be changed, but they've been using historic resource allocations because they're quite problematic. And then finally, the fact that they no longer do the planning and needs assessment as we understand commissioning to mean.
So are CCGs then driven by different agendas, different mechanisms than previously existed? Do they have other bosses, if you like, than the patient?
Well, they're accountable to the NHS England, the NHS Commissioning Board, which is the correct term, not NHS England. And they receive a large bulk of expenditure, as you know, but it's pretty opaque how they're operating now and what they're actually doing with the removal of public health functions. But their duty to arrange to meet the reasonable requirements rather than a duty to provide means that the contract is centre stage, and increasingly using commercial contracts, procurement and competitive tendering.
I wanted to ask you a little bit about that. I wonder if you just turn up, please, page 1763. It's in the same bundle. And this is a submission from a gentleman we're going to hear from later on. And he talks about his involvement with CCG tendering panels. And what he says is this. He says, in this case it's the Hounslow, the HCCG was staffed by individuals who had no prior experience of purchasing goods and or services. And evaluating tenders, the panel were never shown any facility operated by the tenderer. There was no systematic review of tenderers' capabilities. One of the potential bidders for diabetic intermediate care was an industrial gases supplier. Now, I wonder if you could help with your view about, your understanding about the level of expertise on CCGs with commissioning and procurement.
Well, I suppose there's two issues. One is, do CCGs have the expertise? And of course they don't if they're drawn increasingly from general practitioners, GPs and others, for commercial tendering. And the two questions are, one, is this an appropriate way to provide a public service using the very expensive mechanisms of commercial tenders? And second, is it appropriate? Is there experience in tendering? And clearly there isn't experience in tendering, just as there wasn't any experience in doing PFI contracts when hospitals were drawing them up. They were heavily reliant on management consultants and external advisors. So this is what you see. There isn't the experience, there isn't the knowledge about procurement and competitive tendering. But even if there was the knowledge, then is this an appropriate way to arrange for the provision of a public health service and national health service? And clearly we know from international evidence, the US being the best case in point, that this is totally inappropriate, it's very wasteful, because it involves establishing a new market bureaucracy. So we had an internal market which established a new bureaucracy on top of a public administration which was very cheap, 6%, 5 to 6% of the total budget. That doubled when we brought in the internal market, and one can hypothesize that we're probably rapidly approaching 20 to 30% of the budget when we see a move to a market bureaucracy, because you need a completely different system to manage the risks and costs of care. And that's when you're bringing in a market bureaucracy.
I wanted to ask you about the consultancy contract figure that I took another witness to. It's the same volume, it's page 1805. If we look at some of the items, if we look at the first page, there's an item, second down, M&C Saatchi Group, 301,000 and some odd pounds, and the brief seems to be closures of Central Middlesex and Hammersmith Hospital, communications led. We go down a little bit further. There is an item for, at the bottom, June 2014, McKinsey, 1,235,000. Hospital BC Assurance Support and IMBC, and then below that PwC, which I assume is PricewaterhouseCoopers, single OBC and individual specs for Central Middlesex Hospital. Can you help us with what your view is about these types of spend, please?
Well, they look to me, well, first of all, these contracts don't actually have any meaning to me when I read through them. The second is they look scandalously high, and I would be very interested to see what services they're actually say that they're providing for these contracts. And third, of course, many of the providers of these services have actually been drafting and helping draft government policies like McKinsey's PwC. So they've been very much behind the policy of denationalising and privatising the NHS, so they're standing to gain quite a lot.
So can I ask you?
But I find it shocking. I find it absolutely shocking, but it's not atypical. I think if you looked in every CCG in the country, bar a few, you would find exactly the same pattern. So we've got public squalor and private gain actually happening here on an extraordinary scale. And I can give you examples from my own work where I've been working with the College of Emergency Medicine. We don't collect any injury data, proper injury data on an injury's most common cause of morbidity or mortality. It would be a very simple thing to do. It would require a few £100,000 of investment, and the government won't invest in things that are going to improve our prevention strategies and the quality of care and lives of patients and their families. And yet we're seeing these sorts of contracts being awarded.
I think earlier you talked about firms being involved in the governmental development of policies. Are you saying that there is a conflict of interest?
Absolutely, no doubt about it.
Just looking over at the next page, it's 1807. There are a couple of items which look much smaller. There's one at the top and it says 7-day service Hillingdon Hospital, £65,500, and I think there's another one of a sort of similar amount, £40,000 underneath for Ealing. Those appeared to me, and I wonder if you can have a look and tell me if I've got this right, those appeared to me to be contractors which were involved in provision of actual services as opposed to provision of communication services or strategic implementation. I wonder if I've got that right or not.
But could you just point me?
Top of page 1807, the first two items, June 2014, 7-day service Hillingdon Hospital, 7-day service Ealing Hospital. I wonder if you were able to help with whether those were...
I don't know. I'd have to look and see what they say they're doing. I don't know what S&T support is.
And just while we're on that page, the third item, 4,400,000 to McKinsey and Company, whole systems integration program. Obviously, you can't say from that what the totality is, but are you able to give any comment on your view of that size of spend?
Well, again, I think it's shocking, and I know from experience in North West London that they've had a bad or a good track record of using McKinsey's. And I know the people in the public health department were very concerned because McKinsey was penny dash in particular. Their charges were at more than £2,000 or £3,000 a day, and they said that they were providing good value because NHS was one of their favourite customers, so they were giving them a bargain rate. And this was actually before the 2012 Act, but the staff there were so frightened about losing their jobs that they didn't speak up. But I saw the internal documentation at that time. So one would have to ask, what's the basis of this £4.5 million, and is it £2,000, £3,000 a day for the consultants? And that's exactly the sorts of fees we would see under the private finance initiative as well, when you had the tendering process going on.
Now bearing in mind that the total of that document adds up to just under 14 million. It's £13,764 and some odd pence. Do you know where it's coming from?
Well, the money must be from the NHS, from the NHS funds, because there is no NHS now. But it'll be coming it'll be top sliced. I imagine the CCGs are using that as part of the allocation they get from NHS England. That others may be able to confirm.
Now you talk about risk, and you talk about, moving on from this, you talk about risk from contracted services. What happens if a CCG can't find a firm or an organisation which is willing to provide a particular service? So if they can't commission anyone to take the service on, what happens?
I have no idea.
Are you aware of any fallback provision?
Well, you see, they only have to arrange to meet the reasonable requirements. And one way of abdicating your responsibility, a bit like the Secretary of State, was not having a duty to provide, but also using a contracting mechanism. So the government's very keen on this new idea of a prime provider model, where the prime provider will get the budget or the capitated budget, and then they will do the subcontracting in turn. But we know from the American experience that when you move into market contracting, what we're doing in the UK is we're importing American solutions, and at the same time we're going to be importing American problems. Because of course, all contractors want to be able to identify the risks, allocate the risks through the contract, and price those risks. And they're risk averse. We saw that with the Independent Sector Treatment Centre programme, the £4 billion programme that the government put out for elective care, that the private sector had very strict algorithms as to which kinds of patients they would take and which patients they would accept. And so it's very interesting to note that the government is giving new permissive powers to providers and foundation trusts to actually begin to set up eligibility criteria. And this is a matter of speculation now, but the advantage of using a contract is you give the contract to a large prime provider, which in turn subcontracts out the care, and then people will fall through the net. They either won't get it or they'll find they're no longer eligible for care. But this is speculation now. This is the territory we're moving into.
Is the totality of the evidence about that you're giving then, that as far as you are aware, if a contractor cannot be found to take on a service, the service may simply no longer exist?
Yes, or the contractor may agree to take on that service, but it's not properly defined and specified in the contract, and you find that the services fall away. Because that's really what's happening, is we're finding services are falling away. So if I give you the examples of community services, where Virgin, for example, has huge contracts, if you look at the contracts for over £700 million, the risks aren't actually set out or specified in any way, and neither are the services tied down. So, and community services are a very nice one to contract out, because it's very difficult to define them, there aren't very good data, very difficult to specify. So the providers are going to be left deciding who and what they'll give, and they will have very crude outcome measures as to what they'll do. So really what you can find is that service will simply fall away and not be provided anymore, and patients will be going without care, as has been happening for quite a while.
Will it save any money?
Of course it doesn't. Commercial contracting never saves any money. We know that from the US. We've got decades and decades of evidence to show that the move to use a commercial contract is very expensive. The Institute of Medicine in 2012 has shown that the use of commercial contracting results in overtreatment, undertreatment, the denial of care, and enormous transaction costs, which they've put at nearly $700 million. So that's around 5%, 6% of the American gross domestic product spend on healthcare. That's in a year.
Can I just ask you very briefly to deal with the tariff system? And I've already taken a previous witness to that. Can you explain to us what it means for people going to A&E? What it means in terms of the services available for them?
Well, it's simply all market contracts have to have a price mechanism. So the tariff is just a pricing mechanism. I don't know how you can translate what it means to the individual. Much more concern is what CCGs are actually contracting for. So we know now, we've got stories coming around the country where people are now being turned away from the hospitals they used to go to because their CCG no longer has a contract with that provider. So there was an 83-year-old woman got in touch recently to say she'd been turned away from the Queen Elizabeth Hospital, where she'd been attending for 40 years with severe, when she presents with empyema, she has chronic bronchiectasis, lung disease. And her consultant in that hospital said the only way she could get in was actually by coming in through the emergency department. but she couldn't have a direct referral because the CCG no longer had a contract with Queen Elizabeth Hospital. So what you'll see increasingly is that patient choice, and that's what we were sold the 2012 changes, that GPs would be in charge and that patients would have a choice of where they went. Patient choice is no longer the case. It's down to the commissioners and to the providers which patients they will pick and which patients they'll choose and who will get in.
So can I ask you this? In this area, for example, supposing somebody was a patient who usually went to Charing Cross Hospital, and under the new scheme, a new service had been set up at Charing Cross Hospital. If their CCG chose to get that service from somewhere else, are you saying they would no longer be able to go to that hospital? No. They'd have to go elsewhere?
They would have to go elsewhere.
So could we
if
find
there's no contract? If there's no contract, then they wouldn't be able to go to that hospital.
So could we find ourselves in a situation where the reconfiguration takes place and new hospitals are built and services put in place, but they then remain unused because the CCGs have chosen to contract elsewhere? Is that a possible scenario?
Well, I don't think we're going to see any new hospitals built through the NHS. I mean, that's not.
No, I'm talking specifically about the reconfiguration of for example, the change in services at, say, somewhere like Charing Cross.
Yeah.
So supposing there is a unit in Charing Cross which is set up, do the CCGs have to use that unit, or can they say, well, we know it's here and we know it's new, but we can get it cheaper somewhere else?
Yes.
So you could have, what I'm asking is, could you have facilities, new facilities, which remain underused?
Yes, and that's been happening for quite some time. I mean, good examples are the Independent Sector Treatment Centre, or even before that, the fund holding in the internal market, where decisions were being made by the commissioners, and that actually had a knock-on impact on the viability of local hospitals and services. So, of course, yes, it would. That's just the way markets work.
I just wanted to ask you very briefly just to talk a little bit about foundation trusts, and because you've touched on their ability to provide a mixed economy of private and NHS care, and I wondered if you could just expand on that a very little bit, please.
Well, the government abolished the private patient cap in the Health and Social Care Act, which now means that foundation trusts will be, your NHS hospital will now be 51% public and 49% private. So the foundation trust now has the power to raise up to 49% of its income, use up to 49% of the beds and staff for purposes other than NHS patients.
And are they able to do that regardless of the needs of the population, or is that something that has to be factored in?
Well, they're supposed to. There are legal checks in the Health and Social Care Act, but the extent to which those legal checks have been complied with isn't clear. And there is some disagreement over the proportion of income that they can actually gradually, increase the degree to which they can raise their income. But these legal checks are not being monitored, the other thing to say is that the definition of foundation trust income is really now quite problematic, because there isn't good guidance from the Department of Health, Monitor or NHS England on how to define and measure non-NHS income. Now, the other thing that some foundation trusts are doing is that they can get into joint ventures, and so therefore they can appear to remove some of their income from the balance sheet as well, to appear to comply with the legal checks. So this is an area that needs much more scrutiny. But actually, rather than scrutiny, I would advocate that we abolish foundation trusts and we would abolish the internal market.
Thank you. If you'd like to wait there may be some questions from the commissioners.
Yes, thank you very much, Professor. There's certainly are some questions. I'm conscious of the time, but I think we'll overrun. But you made a remark a few minutes ago, almost a throwaway remark, but I want to pick you up on that and get you just to expand a bit. It may be obvious, it may not be. The remark was, there is no NHS now. So I'd like you to expand on what you mean by that. Secondly, Fragmentation has begun, as you've already outlined, from 1990 onwards, with the internal market and so on. And I'm interested in accountability in relation to this. Have you done research, if you haven't, there's a short answer, on the vested medical interests within the House of Commons and the House of Lords, who take decisions about the involvement of the internal market in the NHS? And thirdly, what does the CCG really represent, democratically speaking, and their accountability to the commissioning body itself? So there's three interrelated questions in a way.
Okay, well I'll deal with the second one before I come back to the first one, because I haven't done any research on vested interests in the House of Lords and Commons, though others have. I think Spinwatch and other organisations, so we can easily get that to you, which showed that many of the MPs and the Lords who were commenting, debating and voted on the Health and Social Care Act legislation did have vested interests, and perhaps one of the best known is Alan Milburn, of course. So they have vested interests, conflicts of interest, in that they are often sitting on the boards of some of the private healthcare companies. So that's one substantive. There is research, but I haven't done it. There is no NHS now. Well, the fact is that the duty to provide is the thing that made an NHS. Duty to provide listed services throughout England is the NHS. There's now only a duty to promote on the Secretary of State. So the Secretary of State's abdicated from that duty. There is NHS funding. There's funding for health services, which is why it's called the Health and Social Care Act. It's not called the NHS Act, the 2012 Act. So there is funding for health and social services. That funding is likely to decrease, and the duty to provide, which was the check on market contracting, means that now CCGs are unfettered. They can enter into commercial contracting, and indeed they're expected to under Section 75. So that money is now increasingly flowing. I suppose sometimes you have to use the metaphor of the oak tree, and think of the NHS as like an old oak tree, and the duty to provide were the roots, and the funding flowed through those roots to all the different parts of the NHS throughout England. Those roots have been completely severed. So when you take that duty to provide away, that the roots have been severed. So now where is the money flowing to? Well, it's flowing at random to commercial contractors, regulators, the monitor, into an entirely new system. And that's maybe it's very difficult to explain to the public, because they see hospitals and foundation trusts, but they're not there. Now, if you sever the roots of your oak tree, it doesn't fall down just overnight. It begins to wither away slowly, so the bits wither away, the branches fall off, they drop off, and then finally the whole thing's gone. So what we're now seeing, in the words of the former CEO of the NHS, is a managed decline of the NHS. The NHS is actually withering away. And actually the bit that's now being targeted is the District General Hospital, or the acute hospital system, because that's where the fixed costs are, and that's where the staff are. So this is the context within which you've got to see these big changes happening in North West London, and the government's desire to cut or half the number of A&E departments throughout the country. And the way in which they do that is through putting various different mechanisms. You've got the mechanisms of trust mergers. Trust mergers make it easy to close hospitals. You've got the mechanism that the government can still create and manufacture trust deficits. And this is a story that needs to really come out, and Sean and Roger have shown this, that you create apparent failing trusts in order to take them into special administration, or to make a case for change. But as has been shown, these deficits are sorcery. They're not actually real when you look across the whole system, which is actually in balance. It has a duty to be in balance. But the beauty of having the internal market and foundation trusts is that you can then, like a puppet master, you can put these hospitals into deficit, make them fail, and then that then drives the rationale for service reconfiguration and service change. But actually, it's speculative, I know, but the bottom line is that we no longer have an NHS. The government's putting in place mechanisms which allow the breakup of the NHS, money to flow to commercial providers, which then destabilises what remains, and then the government's got to manage the decline and the erosion and ultimately the closure of what remains in the NHS. So increasingly you'll have fewer and fewer district general hospitals, fewer and fewer A&E services, and that, the rhetoric of course is centralisation is good, specialisation is good, but we've already heard the volte-face that the government's doing, because a lot of the hospital closures throughout the 1990s were driven by the fact that they weren't safe. We shouldn't have, we couldn't have emergency care going in there because they weren't safe any longer, and yet now we've got the government creating new urgent care centres and proposing much smaller hospital units, which will not be comprehensive in the way that district general hospitals is. So this is a final assault on the district general hospital, which was really important because it was symbolic for people in their area. The area health authority or the primary care trust, the residents there identified with their NHS through their local hospital and through the local district general hospital and community services that were already provided. And that's what's actually happening. So when I say that there's no NHS, we have a completely new systems that are being put in place to drive the withering away and manage the decline of the NHS in order to pave the way for commercial contracting, and increasingly what we'll see is a mixed funding system. So patients will find that they're denied care, or they can't get in, or the A&Es are too busy, so they turn to use alternative sources of funding and alternative providers, those that can afford to pay. And you have to remember that the CEO of NHS England is Simon Stevens, who spent a considerable amount of time working for United Healthcare.
I just want to take you back, Allyson, to CCGs, and commonly depicted in the media as GP-led. But I just wanted to explore that a little bit. I mean, to what extent is there in legislation any obligation for CCGs to actually consult with member GPs in their area before taking a decision?
I haven't looked at the legislation again. I need to go back and look at that. But we do know that GPs in the area don't feel that they've been consulted, and they have no role on CCGs. So that's probably the way I'd rather answer that question. But I would put it to you, the evidence that you've seen is that CCGs aren't GP-led, they're management consultant-led and management consultant-driven.
And the other thing, you draw out the contrast between the role of the CCGs compared to the previous primary care trusts, for example. But also, I mean, one of the other things that abolished was strategic health authorities. Now, I'm no great historic fan of strategic health authorities, but one thing that the great NHS London did in its final few years was to actually raise a levy across London from the commissioners to help to stabilise the trusts, some of the trusts which have got extremely large debts. Now, my understanding is CCGs have no obligation whatever to the stability of local NHS or former NHS services in their areas. Am I correct on that? And how do you see that as part of the whole new system?
That's correct. They really have a duty to arrange, which is a duty to contract. They're under huge financial pressure, or perceived financial pressure, so they will obviously contract out to the lowest bidder more often than not. The other thing that's happening is, of course, CCGs don't represent the interests of all the residents in their area, except for emergency care, only their members. CCGs, there are two big changes that are taking place. GP practice boundaries have been dissolved, so that CCGs in theory could be drawing members from anywhere in the country. So that takes you to an insurance fund or an insurance pool. Very important to remember that. The GPs and the BMA opposed the dissolution of GP practice boundaries, but the government pushed that through in January of this year, which means that now CCGs will be drawing and can draw members from anywhere in the country. GP practices in turn are no longer representing their local community. They're federating, they're integrating across areas. So you're going to get federated corporate structures which no longer are accountable to the people in the people in their local areas. And so too are hospitals and foundation trusts. They're all what the government calls integrating in market terms. You've got vertical integration and horizontal integration taking place. But of course, as providers merge, there's no longer any local loyalty to their local community. And as CCGs merge and their membership base changes, and they become much more like insurance funds or insurance pools, they're not loyal to their local community. So if you take Aviva, your car insurer, Aviva doesn't really care about making sure that everybody in my area, where I live in East London, is covered, has a good and adequate coverage and can get access to good house or car insurance. They're interested in whether you can pay the premium or not. And that's increasingly, I think that's the really big transformation that nobody's talking about when you said there's no NHS. The NHS is withering away, but there's a new transformation which is moving much more to a US type of model, what's called the Health Maintenance Organisation, or ironically, the Accountable Care Organisation, which is premised on insurance pools, membership-based, and where you've got integrated, enormous healthcare providers. And the key is there's no local accountability to the local community or the local area. And that's where the government's, all these incremental changes since 1990 have been striving to take us. And this is what 2012, the removal of the duty to provide, finally does. And that's why we're hearing such a lot about Manchester devolution, for example, where we're going to get local authorities and CCGs coming together to co-commission with no overarching duty to provide, no national framework legislation in place to do that. And that's why we're hearing that £1.5 billion Staffordshire contract for cancer services going out to tender, being unbundled. And that's why we've got the context for the North West London experiment as well.